Hi, super friends. Dr. Don Stater here. Let's start this episode with a single number, 100,000. In April of 2021, according to the CDC, we eclipsed 100,000 Americans who died from overdose in a single year. Deaths driven by the despair, stress, and increased substance use that has come with COVID, a tragedy fed by fentanyl and a more dangerous drug supply, and a cancer that has been allowed to grow in the shadow of medicine, government, and society's ineffective adoption of life-saving evidence-based strategies to mitigate overdose risk, provide evidence-based treatment for addiction, or even know how to talk to and educate patients on safer drug use. This can no longer be the approach we take to drug use and drug use education. In this episode of The Antidote, we're going to talk about harm reduction and the fact in 2021 and beyond, every medical provider should know how to inject or consume drugs and how to do so safely. Not so that after a hard shift you can go home and use drugs, but so you can arm your patients who do use drugs with the knowledge they need to keep safe. We're going to divide this subject into three parts. Part one is what is harm reduction and how do you prevent overdose in your patients? Part two is how to prevent viral infections. And part three is how do you prevent invasive bacterial infections? Along the way, we're going to arm you with the knowledge and facts that you didn't get in your training. And you'll be able to positively affect a patient's life at the bedside and beyond, even if, gasp, they continue to use drugs. Because let's be honest, most people seen in hospitals for drug use or complications thereof are not ready to quit. But while a patient may continue to use drugs, that does not mean they're not worthy of care. I treat a lot of people with heart disease who eat bacon double cheeseburgers like a second job, a lot of diabetics who still suck down candy and sodas, and people who've had skin cancer who continue to bake themselves. The fact that you don't hear a lot of clinicians complaining about enabling those patients with their other valid diseases simply demonstrates the double standard around substance use disorders. People deserve compassionate care, even if their behaviors directly undermine our medical recommendations or treatments. In fact, if you want to make your medical treatments more effective, the best way to do so is by showing a patient that you are not judging them, but that you're caring for them. After all, they don't come to hospitals for judgment, they come for care. And as the old saying goes, a patient won't care how much you know until they know how much you care. And this holds especially true when it comes to people who use drugs. So, what is harm reduction? Harm reduction is a pragmatic approach to any risky behavior that seeks to reduce negative effects. Optimizing safety is the heart and soul tenet of harm reduction. It accepts the person and their disease, and that people are complex beings that don't always do what's best for them. No one does. For example, many people decide to use their time watching Keeping Up with the Kardashians, despite irrefutable evidence that this show causes irreparable brain damage. Did you know that there are 20 seasons of that show, by the way? 20 seasons of Kardashians? But I digress. There are many examples of harm reduction in our society today, such as condoms for patients with risky sexual behaviors, designated drivers for individuals consuming alcohol, seatbelt and helmet laws for cars and motorcycles, and the sage advice to avoid politics when sitting with your family over Thanksgiving dinner. That's harm reduction. When it comes to drug use, harm reduction can encompass a wide range of health and social services for both people who use illicit and illicit drugs. These include, but aren't limited to, drug consumption rooms, needle and syringe exchange programs, drug checking, especially for fentanyl, overdose prevention and reversal training, naloxone, and the provision of information, evidence-based information on how to use drugs more safely. Some of these interventions are easy to implement into medical practice, and all of them are cost-effective, evidence-based, and have a positive impact on individual and community health. In fact, we've already done this in the past for taboo, stigma-impacted behaviors. And here I'm talking about sex. As a medical student, I was taught a lot about the public health and individual impacts of sex and risky sex behaviors. I was also taught how to counsel patients on safe sex because We had been through an HIV/AIDS epidemic in the 1980s that killed tens of thousands of people a year because gonorrhea, chlamydia, syphilis, HPV, and unwanted pregnancy can all negatively impact individual and population health. So we were taught how to identify if someone is engaging in risky sexual behavior, to ask the awkward questions, then to inform patients of the fact that different types of intercourse carry different transmission rates for HIV and disease, the fact that using barrier protection like condoms prevents infections, and encourage contraceptives to prevent unintended pregnancies. We encourage sexual safer behavior in medicine because telling people just say no to ever having sex again would be stupid. It would fail the patient and make a mockery of my role as a doctor, which at the end of the day still means teacher. So why in 2021 do most healthcare workers not have a damn clue about how to use drugs or safe drug use, other than telling patients the textbook answer of drugs are bad, don't use them? If we want to actually service our patients, we have to get beyond the Mr. Garrison, Nancy Reagan simplistic approach to drug use and education. We have to know about safer drug use beyond flippant, abstinence-only based advice. Right now, standard care for a person who overdoses is to be resuscitated, allowed to sober, perhaps given a referral to a treatment center, and then told to stop using drugs. That's it. That's not great care, because what we've done is absolutely nothing to ensure that patient doesn't overdose another time and won't end up with the same catastrophe or worse in a body bag. It's bad. It's stupid medicine, and we have to do much, much better. Now, I know what you might be thinking. Don, we can't just teach people how to use drugs. That sends the completely wrong message. Won't that embolden people and enable them and make them more likely to continue with said drugs? Quite frankly, no. The moral hazard argument is deeply, deeply flawed. And if you believe that we shouldn't counsel patients on safer drug use, then by the same logic, you believe that seatbelts should be taken out of cars because they encourage speeding, that sunscreen should be removed from shelves because it encourages excess UV light exposure, and that helmets should be taken away from football players because it encourages more violent contact. All those interventions have moral hazard arguments against them, but all those interventions save lives. So let's not be ridiculous. And speaking to you as a board-certified addiction and emergency medicine physician, embrace harm reduction for people with substance and opioid use disorders. Now, how do you do that when it comes to giving patients good advice on how not to die from an overdose? One, never use alone. People who use alone and overdose die. Always try to use with someone that you trust, who can call for help or administer naloxone if you overdose. Number two is don't mix. People who mix opioids with downers like alcohol, benzos, barbs are at increased risk of overdose. Encourage patients to use just one substance at a time. Three, only ever prepare and inject yourself. It's not uncommon for people who use drugs to start using with someone else, for the other person to start drawing up and injecting them with product, but this limits that patient's control over what they're ingesting. So encourage patients to know how to inject themselves. Four, know what's in your product and use fentanyl test strips. According to preliminary data from the CDC, from April 2020 to April 2021, drug overdose deaths associated with fentanyl totaled more than all drug deaths in 2016. Fentanyl deaths are just skyrocketing. And in general, people who use opioids do not want to use fentanyl. Drug traffickers push fentanyl because it is much more potent than heroin and much more easy to smuggle. Fentanyl is being used by cartels and drug dealers to spike drugs that aren't even opioids. So people who are using meth, Molly, ecstasy, Xanax, or marijuana can sometimes be unknowingly using fentanyl. If a drug user knows there's fentanyl in their product, they can take additional steps to be safe or make the decision not to use the product. 5. If you're using new product or using for the first time after a period of cessation, use a much lower dose or tester dose strategy. The data tells us that one of the highest incidences of fatal overdose occurs after someone gets out of prison, a hospital, or a treatment facility. because they've been abstinent and their tolerance is decreased. So when those patients return to use with the same amount of heroin, fentanyl, opioid that they've used previously, they unintentionally overdose. Or when a new dealer or product comes into a drug market, it can be many times stronger or adulterated with fentanyl. So encourage patients to take small test doses or more than half their dose after periods of abstinence or with new product. 6 is always carry naloxone. Fans of this show know how passionate we are about getting naloxone into people's hands in any formulation. It is simple to use and it saves lives. Educate your patients that use opioids about its benefit and make sure any patient at risk of overdose leaves your emergency department or hospital with naloxone in hand. So let's summarize. Never use alone, don't mix, be responsible for your own drug use and injection, know what's in your product, use tested doses or decreased doses with new product or after abstinence, always carry naloxone. If you counsel patients on this, you will dramatically increase the chance a patient not only doesn't overdose, but you will increase the chance that they get the help that they need, because there's only one definitive requirement for a patient to enter into treatment or recovery. They have to be alive. This is Don Stater, signing off for The Antidote. Overdose is preventable. Clinicians, it's on you to know how to counsel and educate patients on overdose prevention. And 3, let's give naloxone to everyone at risk. Have a great day.